Okay, so we are going to go over chapter 29, and these are disorders of gastrointestinal function. So now, what we're talking about with the GI tract is we're talking about a tube that runs through the entire body. Here, I'll use a different color here. So this is a tube that starts from your mouth and then moves all the way through. So it starts with the esophagus, and then of course we have this enlargement that is the stomach, and the stomach of course is its own organ. Okay, so it's got a sphincter here and it's got a sphincter here that can hold the contents in the stomach. And then that continues through the duodenum, which is the first part of the small intestine, and then it continues through the rest of the small intestine. Um, and then it moves to the large intestine, or the colon. Um, or the large intestine here. So you've got the ascending, the transverse, and then the descending colon. Um, and so when we talk about, most of the time when we're talking about the large intestine, we're talking about, um, we'll refer to it as the colon. Now the cecum is the first part, but then we have the inverse, or the ascending, transverse, and descending colon. Okay, so most of what we're going to be talking about today is damage to the layers of the of this tract, okay, this tube that moves through. And so we need to kind of be aware of a couple of things. So first of all, we're going to talk a lot about the mucosal layer. And the mucosal layer, it's where there's absorption, depends on where you are, but there's absorption that takes place and there are enzymes that can be secreted there. But most importantly, there is mucus. And so mucus is secreted in this mucosal layer, and that mucus serves a protective role. So that way your stomach and your intestines don't digest themselves. This mucosal layer will form a barrier that prevents that from happening. And then on the other side of that, sort of the middle layer, is the submucosum. So the submucosal layer sort of sits out here in this area, okay. And then outside of that is the muscular layer. Okay, so the muscular layer is what, well, it has smooth muscle, and the smooth muscle is what causes the peristalsis, and it causes the motility, and it moves stuff through the intestines. Okay, so kind of keep that in mind. The mucosal layer is that inner layer, and then the submucosal is kind of the middle, and then the outer layer is this muscular layer. Okay, so we're going to move through it in order. So as the same order that food moves through it. So we're going to start in the esophagus, and then we're going to move in through the colon. Um, so we're going to start out talking about a couple of swallowing disorders. So the esophagus is where the food moves from the mouth into the stomach. And so a couple of swallowing disorders. Dysphagia could be difficult or painful swallowing. Okay. So that can result from narrowing of the esophagus, lack of salivary secretion. So saliva is supposed to lubricate the food and keep it more fluid. So dysphagia, you could have difficult or painful swallowing simply because you're not producing enough saliva, and so that's not going to. So food is going to be a little bit more chalky, maybe going down than it should be. Weakness of muscular structure, so that muscular layer that surrounds the esophagus and all of the GI tract could cause could become weakened, and that could have a harder time getting food to move through the way it's supposed to. That peristaltic movement that pushes food through the esophagus and down into the stomach. That weakness could cause some pain and difficulty there. And then, of course, disruption of neural networks. So anything like MS or something like that that interrupts the neurons that are supposed to be coordinating this peristaltic movement to sort of initiate that movement of food down. If you have neuronal damage, well, that's going to cause the same types of problems. Okay, so that's dysphagia. Achalasia, so the A means not. That's a failure to relax. Okay, so there is something that sits right here, the lower esophageal sphincter. So sphincter muscle is just a round muscle that can constrict and cut off flow. Okay, so that's what sphincter muscles do. Is they sort of squeeze. They're rounded, um, and they squeeze. In this case, in achalasia, the lower esophageal sphincter does not relax enough. Okay, so it's supposed to relax, open up, and allow food to move into the stomach. So if it doesn't relax, then that means that food doesn't completely move into the stomach, and so it may cause food to collect, and you may see this esophageal dilation above the lower esophageal sphincter. Okay, so that means that that food that's supposed to move into the stomach isn't quite making it, and so you may see something like aspiration. When you're lying down, that food may creep up, or some kind of reflux or regurgitation of that food. Something may happen because that lower esophageal sphincter is not relaxing the way it should be. Okay, so as we move through, this is kind of interesting. The esophagus actually goes right through the the diaphragm muscle. Okay, so we can see this here, and that's what a hiatus is. Okay, so there's the esophageal hiatus, and that there's a little hole, and that hole's supposed to be there, and that's how the esophagus moves through. We can see another hole over here, the venocaval hiatus, and then we can see the aortic hiatus here. But we're interested in the esophageal hiatus right now. And these are just holes in the diaphragm. So the diaphragm is supposed to be, when it contracts, it pulls on the pleural cavity and causes your lungs to inflate. But this little hole allows food to move through it, okay, through the esophagus. Now, a hernia is where you have some kind of tissue that's pushing through a hole. Okay, so those two things together can cause something called a hiatal hernia. And that's where the stomach, and you can kind of see it in these pictures, the stomach pushes through that esophageal hiatus, and part of the stomach will end up above the esophagus. Now, there are two types. Sliding hiatal hernia is a protrusion of the stomach above the diaphragm, okay? And that's very common, usually insignificant, and often asymptomatic. You may not even be aware that it's going on. And that's because the contents aren't trapped. So you still may have, you may experience an increase in gastric reflux, but it may not be something that the person is particularly aware of. They may just think that they've got a little problem with that. So, but food continues to move through. Okay, so it doesn't get trapped. It's not ideal, but it will still move through. The problem comes in with this one, which is the paraesophageal hiatal hernia. Okay, so the sliding hiatal hernia may be asymptomatic, or the perception of it is that it's asymptomatic. But the paraesophageal hiatal hernia, that means that part of the stomach enters the thorax through a widened opening. So you actually see a pouch that develops. So you can kind of see that here. You actually see a pouch that develops outside of, or on top of, above the diaphragm. Now this can be a problem because in the case of the sliding hiatal, it was sort of moving through, not ideal, but it was moving through. In this one, food can still move in, but you're going to reduce the flow in this little pouch that forms, okay, in the herniated part of that stomach. Okay, so that means, what that means is the contents may become trapped in there. Okay, when you have contents that are being trapped and you're trying to, keep control over the enzymes that are being produced, the acid that's being produced, the stomach that's moving in and out, or the stomach contents, the chyme or the food, then that's going to be interrupted, and that can cause a lot of problems. It can cause some kind of herniation maybe, or it may cause there's going to be a buildup of acid. You might even get that area is going to be more prone to infection. And that's all because the contents may become trapped. Now, we see this more, it's more common in people over 50, and it's pretty much generally caused by diaphragm muscle weakness. Okay, so this diaphragm may become weakened, and then that stomach, any kind of excess pressure may push a little bleb of this pouch out of the out on top of the diaphragm. Okay, um, so I kind of mentioned this gastroesophageal reflux. So gastroesophageal reflux. Gastro always refers to the stomach, esophageal, obviously the esophagus, and reflux means that it's pushing back. So what happens is that you have the stomach, and for whatever reason, acid is being pushed back up into the esophagus. And so we notice this as heartburn, and something that happens to, pretty much everybody. I think everybody has experienced heartburn from at one point. I'm sure there are some people who have not, but most people have. And so this is kind of something that happens. So every now and then there is some regurgitation or reflux back up into the esophagus. And so that's gastroesophageal reflux. Now, what the problem is, something like when it's persistent. Okay, so gastroesophageal reflux disease is when you have a persistent reflux of gastric contents into the esophagus. Okay, so that means that there's something leading to it. There's something very unusual uh, that's causing this to happen persistently on a more regular basis. Okay, so this could be an incompetent esophageal sphincter, so that sphincter muscle that's supposed to be clamping it off and closing around it. It may not be working right. It may be weakened, or there may be some other kind of damage that's preventing it from contracting the way that it's supposed to contract. It could be something else. It could be conditions that increase abdominal pressure, such as delayed gastric emptying. Okay, so that stomach, this horrible stomach that I drew, is supposed to let chyme out, which is food mixed with the digestive juices. It's supposed to let it out little by little by little. Well, if that's not taking place right, if there's something wrong where it's building up, then you're going to have an increase in pressure out on the stomach, and that's going to also cause uh, the gastric contents to move up into the esophagus. And mostly what we're worried about is the hydrochloric acid, this highly acidic fluid that moves up into the esophagus. Okay, so manifestations of that: heartburn, obviously. Okay, so heartburn has nothing to do with the heart. It's the burning of the esophagus, regurgitation of chyme, and upper abdominal pain within 1 hour of eating. So in children, so this can happen in children too. Feeding issues, esophageal bleeding from damage that can happen from this persistent reflux. They may become irritable, pain with swallowing, and even may result in respiratory symptoms from changes in pH. Okay, so treated with antacids. Okay, so antacids like Tums or something that's just going to neutralize the acid. H2 receptor antagonists. So when we talk about H2, I realize that after I wrote that can be confusing to people because you might be thinking hydrogen. We're talking about histamine. So histamine 2 receptor antagonist. Histamine is something that promotes, so when histamine is released, it can activate the parietal cells, and the parietal cells are the ones that release hydrochloric acid. Okay, so if we antagonize or we block the histamine, then we can block the release of hydrochloric acid. Proton pump inhibitors like Prevacid or something like that will do the same thing. Okay, so those will stop the actual pump. So while H2 or histamine receptors antagonists will shut down the cells that are doing it, the proton pump actually shuts down the pump. All of these things are going to reduce acidity. Okay, so they're going to reduce the amount of hydrochloric acid that's being pumped in. Okay, and just to make things confusing, that means they're increasing pH. Okay, so that's gastroesophageal reflux. So complications. So what kind of complications can happen? Well, you can kind of guess in a lot of ways. Esophageal mucosal damage. Okay, so damage is happening, and that's related to this acidity, okay, of the refluxate. Okay, so what's being the stomach contents. Um, the repeated damage may form scar tissue. So that's what we see here is a stricture. So the constant damage of this area may cause scar tissue to form, and that scar tissue is going to be less compliant. It's not going. It's going to cause a band of an area that's not going to stretch the way it's supposed to stretch, and then food's not going to be able to get past this as easily, which is kind of, it could actually compound the problem and cause it to be to kind of progress in some ways. Okay, and speaking of that, there's something else called Barrett esophagus. So this is these are complications. Barrett esophagus is when you have this continuous damage. Do you remember from smoking, when we were talking about smoking, we were talking about respiratory cells, and we said that um, the smoking causes the ciliated columnar that's metaplasia, to turn into squamous epithelial cells. Barrett esophagus is the opposite. It's supposed to be squamous epithelial cells, and they turn into columnar epithelial cells. Now, columnar epithelial cells are what line the intestine, most of the intestine. But in the esophagus, these are supposed to be squamous. Okay, so we have the squamous that are turning into columnar. Okay, um, for whatever reason. But the problem with this is that anytime you sort of mess with the nuclear or the DNA, and you sort of start changing gene expression to the point where you're changing cell types, you're increasing the risk of cancer. Okay, so you're increasing the risk of, in this case, an adenocarcinoma in the lower third, and squamous cell carcinomas in the middle of the esophagus. So when you start to see Barrett esophagus, then you can kind of that person would be at a much higher risk for developing cancer of the esophagus. Okay, so other risks that come with that, tobacco, alcohol use, or anything that causes the repeated damage in the gastric reflux, whether it causes the gastric reflux or it's in combination with the gastric reflux, either way, those are going to increase the risk of cancer, gastric reflux. All of those things seem to work together. Okay, so now we're moving out of the esophagus into the stomach more properly. So, um, so the esophagus moving into the stomach. So we're going to talk about a few things. We're going to talk about acute gastritis and chronic gastritis. So these are inflammation of the stomach lining. Ulcerative disorders. So this is where we're actually talking about some kind of perforation that may take place. And so we're going to talk about peptic ulcer diseases and stress ulcers, and then the stomach is not immune to cancer, so some of these things can develop into the constant damage can lead to cancer. Okay, so first of all, we'll talk about acute gastritis. So this is going to be a transient inflammation of the gastric mucosa. Transient, so rapid onset, transient. It's acute, severe nagging pain that does not last long and comes in short bursts. Okay, so if it doesn't last long, comes in short bursts, it could be associated with certain things. Some of the research sort of points to these sort of things, and anecdotal and studies that have been done and reports from people. Aspirin use, non-steroidal anti-inflammatory, oral steroids. These are the most common causes. You may also see just anything, whatever a person happens to be sensitive to. So bacterial endotoxins, that's pretty clear. Some people say they have this effect with caffeine. Spicy foods may cause it. Alcohol, and kind of the list goes on. And it can be anything. Like I said, that a person happens to be sensitive to. And just a reminder here, when we're talking about gastritis, we're not talking about the intestines, we're talking about the stomach. Okay, so this only involves the stomach. Okay, so that was acute. Well, what about chronic? Well, chronic means that it's sort of continuing for a longer period of time. Um, so characterized by absence of grossly visible erosions. Um, so 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 what does that mean? That means we're talking about an inflammation. We're talking about an inflammatory process. So you can kind of see down here that this is some damage. I know this is just a picture, but you can kind of get the idea that you have inflammation of the lining of the stomach here. But what you don't necessarily see is an erosion. You don't see an ulcer that is forming. And so that's when we refer to it as gastritis. Okay. Now, if an ulcer were to form, if you did see this erosion and an ulcer were to form, then we would call it some kind of an ulcer. Okay, so as long as it's gastritis, that means that an ulcer has not yet formed. Now, that's not to say that chronic gastritis can't, or won't progress to form an ulcer, but this is just saying that gastritis, as a term, refers to is sort of boundaried. The boundary is that it's absence of the grossly visible erosions. Okay, so presence of chronic inflammatory changes. So again, we're talking about chronic. Atrophy of the glandular epithelium of the stomach. So this constant inflammation can cause the some cell death, even if it doesn't lead to an ulcer, which it probably would in that case. Okay, so changes may be dysplastic and eventually transform into a carcinoma. Okay, so there are three types that we're going to talk about: Helicobacter pylori, should be a C there. Helicobacter pylori gastritis, chronic autoimmune, and then we'll say a little bit about chemical as well. Okay, so Helicobacter pylori. Okay, so this is going to be a bacteria. So Helicobacter pylori causes damage to the stomach lining. So this is a bacteria that survives very well in the acidic environment, the hydrochloric acid environment of the stomach, and will cause damage to it. Okay, so it used to not be known what this was found. I don't want to say fairly recently, but only about 20 years ago or so, that it was actually that bacteria were actually living in the stomachs, because we think of the stomach and the hydrochloric acid as something that's there to kill bacteria. So to find a bacteria that kind of thrives in that area was pretty unusual, and then to find out that it was pathogenic was even more. I don't want to say it's bad, because it's something that we could treat. So once we found that this was causing some of these problems, it actually opened up treatment options. Okay, so causes damage. So H. pylori causes damage to the stomach lining, secretes enzymes that degrade the mucin. Okay, so remember, we have this mucus lining that's sort of protecting the layer of the GI system, the stomach and the intestines, but it degrades that. Has the capacity to interfere with the local protection of the gastric mucosa against the acid. So by degrading that, then it allows the acid to move in, but the H. pylori also produces toxins that directly damage the mucosa and produce ulceration. So it can start out as this inflammation, and then it will ultimately lead to damage and then ulceration. And the ulceration is where you have the tissue damage, and you may have bleeding. You may have a perforation or a hole. Okay, so H. pylori is the major cause of peptic ulcers. The second most common cause of ulcers are NSAIDs. So treatment. So how do we treat this gastritis that's caused by this H. pylori? Um, Antibiotics. It's a bacteria, so it can be treated with certain antibiotics, which can kill the bacteria. But because the acid is also leading to some of this ulceration that could take place while you're treating it with the antibiotics, you also want to reduce the acid. Okay, so once it's been identified that the H. pylori, which you can see in this picture, are living there, then you want to reduce the acid. You want to kill those off. Okay. to prevent any further progression or any further damage. Okay, so that was H. pylori, and that was also a chronic gastritis. Got to keep those straight. Okay. Okay, and then we have a couple of more that we're going to talk about. A couple of more chronic gastritis that we're going to talk about. Chronic autoimmune. So autoimmune gastritis, which means that your body is attacking itself. Okay? That's what autoimmune means. So 10% of all gastritis, so not too many, associated with other autoimmune diseases like diabetes and Addison's for whatever reason. They are associated with other autoimmune diseases. But here's where we want to kind of slow down and think for a second. Autoantibodies, so what are these autoantibodies attacking? They seem to be attacking parietal cells. Now, why is that important? Because parietal cells produce a couple of things. One of the things they produce is hydrochloric acid. Okay. HCl, I did it that way because it's dissolved, but hydrochloric acid is the acid that's in our stomach. Another thing it makes is intrinsic factor. Now, do you remember what intrinsic factor is? It's a peptide protein, or it's a protein, and it binds to B12 and then forms this little complex that can then be absorbed. Okay. So that can be absorbed through the cell, the I guess the wall of the small intestine, and then absorbed into the blood. Okay. Now, if we are attacking the parietal cells, then that means we're not making the intrinsic factor, which means that we're not absorbing any of the B12 into the blood. Okay, so if you remember what B12 does a couple of things. It is involved in DNA replication, so it's involved in making new red blood cells. That's an important thing that B12 deficiency shows, is it shows this B12 anemia. Okay. Now, another thing that it does is that B12 is involved in making so it's involved in putting lipids on, so do you remember myelin sheaths? Okay, those are made of lipids. Okay, so without B12, this myelin is not produced properly. Okay, so it can cause neurological damage. Okay, so remember that we talked about that as pernicious anemia. Okay, so those two things. So that means that chronic autoimmune gastritis tends to have manifestations that are the same as B12 anemia. Okay, so do you kind of see that connection? And it's because it's attacking these parietal cells that are making intrinsic factor. Okay. Okay, so hopefully that makes sense. And then there's one more, chemical gastropathy. This is really associated with these types of surgeries, gastroduodenostomy and gastrojejunostomy. So those are just essentially what those are. What those are referring to is when maybe you have some damage to the stomach, maybe you have a cancer here, and that's where it goes out to the duodenum. And so you kind of obliterate this whole area, and then you attach the intestine directly to the stomach. Okay, so that's what that is. And so when you do that, you sort of lose the stomach loses its ability to cut off. So there's the sphincter that sits down here. That, well, it's supposed to sit down there. It would sit down there in this functional one, and it's supposed to prevent any kind of intestinal contents from moving back into the stomach. Okay, but when you have these particular surgeries, then you lose that ability, and that means that intestinal contents move back up into the stomach, and that can cause a gastritis, and we call that a chemical gastropathy. And so you see something like, this is what this is saying, chronic reflux of pancreatic and bile secretions. Those things are supposed to be separated. Those things are supposed to be excreted into the small intestine. They're not supposed to reflux back up into the stomach. Okay, so when they do, that can also cause a gastritis. So that's less common, but it can happen. Okay, all right. So what happens when the damage progresses to peptic ulcers? So we end up with something called peptic ulcer disease. So it occurs in the upper GI tract, the stomach, and the duodenum that are exposed to acid. Okay, so that's generally where it happens, in the stomach and the first part of the small intestine that are exposed to acid. And it's just, you can kind of see that in this picture here. So you can kind of see the normal-ish looking tissue, but then you look here and you see where an ulcer has developed. It's sort of broken through, and you've got perhaps some bleeding. It may perforate completely. Um, and so that's a peptic ulcer. So characterized by spontaneous remission, exacerbation. So it may come, it may go, it may get worse, it may get a little better, but it kind of goes back and forth. It may heal up on its own in some cases. Now, usually the cause is H. pylori. So we already mentioned that, Helicobacter pylori, bacteria. That's most common, and we also mentioned that NSAIDs or aspirin may also cause this ulceration. So signs and symptoms: pain. Okay, pain, burning, gnawing, cramp-like pain when the stomach is empty. Okay, so that sort of makes sense. That's when you've got kind of this acidic environment. But then when you eat or when you take antacids, you sort of dilute the stomach contents. You dilute that hydrochloric acid, and that can create some relief from that pain. It doesn't mean the ulcer has gone away, but you do have some relief from the pain. So major complications: a GI bleed. Okay, so a GI bleed where you may actually bleed into the peritoneal cavity. It may cause some clotting, some obstruction, um, perforation. So if it bleeds all the way through, that's kind of what I was talking about with bleeding into the peritoneal cavity. But you can see that these are basically based on the damage that the ulcer is causing. Okay, so there's something else called a stress ulcer. It also has the name curling ulcer. And the thing to remember is that we're talking about physiological, not mental stress. We're not talking about psychological stress. Oh, I'm so stressed, I'm getting an ulcer. We're talking about something that is interrupting blood flow, inflammation, something like that. So related to severe burns, illness, neural injury. So neural injury where you're not getting the proper innervation. Systemic trauma, something like that. Those are the stressors that we're talking about. And so if something leads to reduced plasma volume, if you have redirecting of blood flow or loss of blood or loss of fluid, then you could have ischemia. Where you have ischemia, that can ultimately lead to necrosis. And if you have necrosis, then you've got the dying off of these cells, and that can then lead to ulcerations. Okay, and that's what we're talking about here, is we're talking about a stress ulcer. So we're talking about an ulcer that results from this. Okay, so it results from this reduced plasma volume that's leading to the ischemia, the necrosis, and whatever might cause that. Now, one thing that was noticed is that intensive care unit patients seem to be at a particular risk. So these people who are in intensive care are routinely treated with proton pump inhibitors or histamine H2 receptor antagonists, and these are to reduce the stomach acidity. Okay, until they start to show some recovery. Okay, because it's this acid that really can get in there and cause the damage to occur more quickly. Okay, and then I put something else down here. I'm not too worried about it, but it's called Cushing ulcers. They're ulcers that result from brain trauma which is where you overproduce gastric acid, you overproduce the hydrochloric acid. Okay, so that's neurological from brain trauma. Okay, but this part up here are the stress ulcers, and that's probably something to pay a little more attention to. Okay, so now let's see. We've just moved through the stomach. Now we're going to move into the intestines. Okay, so we're going to cover a few things. Inflammatory bowel diseases. So keep this in mind. When we're talking about inflammatory bowel disease, mainly what we're going to be talking about are Crohn's disease and ulcerative colitis. Okay, these are the inflammatory bowel disease that we're talking about. Then we can see something called infectious enterocolitis. Okay. Infectious refers to some kind of pathogen, and sure enough, viral infections, bacterial infections. Okay, so we're going to talk about those. And then we'll talk about diverticular disease. Okay, so the formation of diverticuli, and we'll talk about what those are. We're not really going to talk about, I kept appendicitis up here, but we're not really going to talk about appendicitis. The appendix is a small thing between the small and large intestine that can sometimes, I think most of us are aware sort of what's going on with the appendix, but for whatever reason it can become infected, or there's inflammation that can occur, and we're not really exactly even today sure why that happens. Okay, so inflammatory. Remember, we're trying to keep this straight. Inflammatory bowel disease. Okay, Crohn disease. So we're first going to talk about Crohn disease. Crohn disease, a recurrent granulomatous inflammatory response that affects any area of the GI tract. Okay, so any area, that's kind of a clue. That's kind of something that separates it from ulcerative colitis, but it can affect any area of the GI tract. Now the cause is unknown. It may be immune related. The age of onset is in the 20s and 30s, but what it is normally, this picture doesn't show it too well. It shows the Crohn disease really well, but normally in the intestine you have sort of this I call it rifling, but it's more of a linear type of structure. What happens with Crohn disease is that you get this, so the intestinal mucosa has a cobblestone appearance, okay, secondary to the presence of the linear ulcerations, edema, and inflammation. So you start seeing a cobblestone sort of appearance, so if that makes sense. And you can see the granulomatous exudate that's kind of moving out of this area. And you also see some stenosis where you have narrowing of the intestine. Okay, so you can kind of see that going on as well. And so they call these, so what you see are something called skip lesions. So it's sharply demarcated granulomatous lesions surrounded by normal appearing mucosal tissue. So you see the lesion that's taking place in this area, and then it becomes relatively normal after that. And then you'll see another one where it kind of does the same thing, okay, a little bit later on. So skip lesions. And some of the, so what's going to happen in these areas where this is taking place is pain, malabsorption. You're not going to be able to absorb things like B12 again, folic acid, so other nutrients that may be needed aren't going to be absorbed efficiently in these areas, and so it really depends on how many of these areas that you have there. So manifestations, bloody diarrhea, okay, because of this granulomatous exudate. Colicky pain, so it kind of comes and goes. In the lower right quadrant, weight loss, fluid and electrolyte disorders, malaise, low-grade fever. So you kind of have this kind of becomes systemic, a systemic inflammatory response. It's slowly progressive and debilitating. Okay, so this is not something that people typically get better from. It's something that tends to progress slowly and get worse over time. Okay, so the other inflammatory bowel disease that we're talking about is ulcerative colitis. Okay, so the first one was Crohn's disease, now ulcerative colitis. And you can see the differences between the two of them right here. Okay, so there are a couple of things to look at. First of all, Crohn's disease, we were talking about these skip lesions, or we were talking about how there was some inflamed material and then normal for a while, and then inflamed again. And it can happen anywhere with Crohn's disease. Ulcerative colitis, it tends to begin in the rectum and then it spreads proximally. Okay, so it spreads in through the colon from the rectum. So they are confluent and continuous lesions. Okay, and this happens in something called the crypts of Lieberkühn. In the base of the mucosal layer. Now we're really not talking too much about that, but this is where it happens. So there are these little crypts, okay? And so that's where the inflammation tends to originate. Okay? So enough research has been done to see that. Symptoms: diarrhea, which can last for weeks, blood and mucus in the stools. Okay, so diarrhea of 10 to 20 per day, so that sounds pretty horrible. Um, but there are some treatments, medications, immunosuppressive agents. So that may have something to do. So immunosuppressants are going to. So there's obviously an immune factor involved in it. Surgery can take place to remove some necrotic tissue or some severely affected tissue. And of course, well, I guess not of course, but with ulcerative colitis, there is an increase in colon cancer risk. Okay, so that has been observed, and that sort of makes sense because when you have the increased inflammation, when you have the increased damage, then that's going to sort of up your chances that some of this cell division may go wrong and cause cancer. Okay. So those were the inflammatory bowel disease, Crohn's disease, and ulcerative colitis. So now we're going to talk about infectious enterocolitis. Okay, infectious enterocolitis, and our wonderful key word here is infectious. Okay, so infectious means that it's caused by microbial agents. So microbial agents, so we have listed here viruses, bacteria, protozoa. These things infect the GI tract, causing a broad range of symptoms. So maybe something, when we talk about food poisoning or something like that. But there are other viruses and diseases that can cause infectious enterocolitis. So broad range of symptoms, but some of these symptoms should start sounding kind of familiar: diarrhea, abdominal pain, perianal discomfort, ulcerations may occur, hemorrhage may occur. So essentially what happens, we're talking about an infection, the intestines are going to try to get rid of it. Okay, so they're going to attempt to get rid of the infectious agent. So there may be a heavy amount of exudate that's produced to dilute the toxins. You may have hypermotility, so there may be an increase in peristaltic activity moving it through. So we've got now, it's more dilute, more watery, and you have higher motility. You may stop moving food through the GI system, which is going to lead to vomiting. So all of these things can happen. We're trying to get rid of whatever this toxin is, whether we're getting rid of it out the back end or out the front end. We're trying to get rid of it. Is kind of the way to think about that. So overall, you're going to see decreased intestinal function. Okay, so increased motility, movement, but decreased intestinal function, which means that food is not going to be absorbed. Osmosis is going to draw water into the bowel, so it's osmotic diarrhea. Right, osmotic or explosive diarrhea is going to take place. So a few of them a couple of them that we're going to talk about. Rotavirus. So rotavirus is a can be pretty serious for kids. A lot of kids do get it. Infants may be hospitalized because again you're trying to flush out this virus, and that's the reaction that your GI system has. You have a lot of vomiting, you have a lot of diarrhea, and that can very rapidly rid the body of water, and so that can lead to dehydration. C. diff, Clostridium difficile. E. coli. E. coli is another one that can, when it gets in there, when a certain pathogenic um, viral strain of E. coli gets in there, can secrete toxins, can lead to hemolytic anemia, uh, thrombocytopenia. So bleeding may occur because you can't form clots. Those kinds of problems. So the two that we're mainly going to talk about with infectious enterocolitis are C. diff and rotaviruses. So C. diff, this is what you really need to understand. This is really important to understand. The primary cause is antibiotic therapy. Okay, so inside your colon, okay, you have bacteria that live there, and usually, I mean, there are lots and lots of them. Okay, and within that, or amongst those bacteria, there can be pathogenic bacteria that live in there as well. Okay, so there are some pathogenic bacteria that live in there. But you have so many bacteria that are sort of competing with it that it won't let them grow. Okay, so it won't let them take over. Now, when you take antibiotics, what tends to happen is some of those good bacteria, or a lot of those good bacteria, may not survive. So you're trying to kill a certain bacteria. Well, the thing is that C. diff may already be living in there. Okay? And so when you kill off those other bacteria, the beneficial bacteria that were competing with it before, because C. diff isn't very competitive, but when those others are gone, it allows it to take over. Okay? And that's where you have the problem. Okay? So that's the primary cause, antibiotic therapy. Uh, and what we call that, we call the C. diff, we call it opportunistic. And that's because it's waiting for an opportunity. It's waiting for some of these other bacteria that it can't compete with to go away. And when those other bacteria go away through antibiotic therapy, or taking antibiotics, that's what that means. Um, then it gets a foothold. Okay. So usually intestinal flora are present that prevent proliferation of pathogenic bacteria, and when those are gone, it gets a foothold. And toxins may lead to hemorrhage, inflammation, and necrosis. So C. diff can be pretty bad. Uh, most of what you'll see is diarrhea and cramping 1 to 2 weeks after antibiotic therapy. Okay, so that's generally what you see, but there are some severe forms that can be life-threatening. It's not something to just be taken lightly. Okay, because it can turn into, or can be very serious. Okay, rotavirus. Rotavirus. This is very common in kids. Um, that was the first time I ever heard of it. Actually, is when my kid was diagnosed with it uh, many quite a few years ago. Okay, so rotavirus fevers. So it is a virus, obviously. Fevers, vomiting lasts about 2 days. So fever and vomiting last about 2 days, but the diarrhea persists for 5 to 7 days. Okay. So even though the kid may feel better, the diarrhea is still there, and it's still shedding, and that's the problem. So affects children ages 3 to 24 months. Viral sheds for several days, even after resolution of symptoms. That's never a good thing, and that's why this can be a real big problem in daycares, because the kid is fine. The symptoms have resolved. The kid seems like he's doing just fine. He's active, and yet he's still shedding the virus. He's still passing it on. He or she is still passing it on to other children. Okay, so short incubation, about 24 hours, and of course, like I mentioned before, there's a risk for dehydration because of the vomiting, because of the diarrhea, and the fluid loss associated with that. Okay, so that's rotavirus. Okay, so diverticuli. Diverticuli are kind of interesting. Protrusions through weakened layers of the intestinal wall. So if you look down here, this kind of gives this is a nice little cartoon idea of what it is, but that's kind of the way it looks in my head too. Um, and you see sort of these outpouchings, these diverticuli that are sort of formed, and they're sort of formed from an increase in pressure. And so as things are sort of squeezing, as food or um, chyme or whatever is sort of being squeezed through the colon, especially, then that additional pressure may push through weak points and so protrusions through weakened layers of the intestinal wall. Now, it used to always confuse me how something like low fiber could decrease your risk of colon cancer. Well, what happens with low fiber is that you don't have the bulk, and the intestines have to squeeze harder to move that food through. Okay, so that's a very simple way of putting it. But that's kind of what happens. And so what fiber does, even though we don't absorb fiber, it's not really a nutrient, it adds bulk, and it allows the intestine to sort of push this food through more easily with a lot less stress, a lot less pressure. And so these diverticuli are less likely to form with a higher fiber diet. Okay, so diverticuli, protrusions through weakened layers associated with low fiber, decreased physical activity, and poor bowel habits. So letting the bowel collect, the feces collect in the bowels, can also lead to this. Okay, so a couple of phases, I guess. Diverticulosis. The mucosal layer herniates through the muscularis layer. Okay, so it's herniating, it's pushing through. But that may be asymptomatic. You can just sort of see it pushing out. Diverticulitis. Okay, so this is diverticulosis. Diverticulitis. Now, itis is going to refer to inflammation. Okay, so diverticulitis is where you have inflammation and perforation of the diverticula. So this diverticulosis, the diverticuli were forming, but then it can progress to diverticulitis where it becomes inflamed, it's perforated, and then you've got bigger problems. So then that's when you start to see the symptoms: pain and tenderness, nausea, vomiting, slight fever. So now we have a systemic um, inflammatory response, elevated white blood cell count. So you see all of these things associated with it once it's moved to diverticulitis. Okay, so the goal is to prevent flares by increasing bulk in the diet. That's what we're talking about, fiber, which increases the diameter and decreases the pressure, and it allows that food or the chyme to be pushed through, feces, whatever you want to call it at that point, allows it to be pushed through more easily. And then regular bowel movements. So that's kind of also something that you would recommend to someone with diverticulosis even, or diverticulitis, is to make sure they have regular bowel movements, and they have fiber in their diet. And then treatment could be with antibiotics, because once you have these perforations, then you've got, I mean, there are a lot of bacteria in there, and you could increase the risk of infection. So antibiotics, clear liquids as well. Okay. All right. So a couple of more things, a few more things that we're going to talk about. Disorders of intestinal motility, so diarrhea, constipation, intestinal obstruction. So we already kind of know what diarrhea is. It's that increased bowel movements, usually a loose bowel movement. Constipation is the opposite, slowed down. And then obstruction, it's where things aren't moving through the way they're supposed to. Okay, so first of all, diarrhea. Excessively frequent passage of stools, diarrhea. Okay, so it can be acute, can be acute or it can be chronic. Okay, so we can see we have a couple of categories of acute diarrhea. Infectious agents tend to be the cause of acute diarrhea. Something is causing your GI system to respond and increase this motility. So um, there are a couple of categories: non-inflammatory, which would also be called large volume. And these can be caused by E. coli, Staphylococcus aureus. And this is secretory. Okay, so we're talking about secretions. So that's where this large volume idea comes from. So it's non-inflammatory. So we're not seeing inflammation, but we are seeing a response. And we're seeing an increase in the water content of the stool. Okay, so we're seeing an increase in water content, which means that you're seeing an increase in volume. It's not going to be bloody. We're seeing increase in water, not necessarily inflammation and damage. But it will be associated with abdominal pain, cramps, and bloating. Okay, so these are non-inflammatory acute. Okay, acute non-inflammatory. Inflammatory: Shigella, Salmonella, Campylobacter. Usually, okay, so were you taking notes? Usually affects the colon. Okay, so inflammatory usually infects the colon. So volume is not significantly increased because really most of what's happening in the colon is absorption. So some absorption of maybe of water, so that may be reduced. But there's absorption of water, absorption of some kind of nutrients, and then you've got a lot of bacteria in there doing their work. So if you have an inflammatory infection of the colon, well, then you start to see, well, fever is going to be associated with a systemic inflammatory response. So you're going to see fever. If you have damage to the colon, you're going to see bloody diarrhea. Okay. Now, there is less abdominal pain, and it's in lower quadrants, okay? Because we're talking about the colon, we're talking about usually the descending part of the colon. Okay, so those are your two acute: non-inflammatory and inflammatory. Okay, so I won't go over them again, even though I'm tempted to. Okay, so chronic. So those are acute. This is chronic, mostly associated with inflammatory bowel diseases. So some of the inflammatory bowel diseases that we've already talked about. Characterized by frequency, urgency, and colicky abdominal pain. Okay, so this is something that is associated with an ongoing problem. So whereas acute tend to be infectious agents that come in, wreak havoc, and then kind of go away, chronic are some of these more long-term inflammatory bowel diseases. Okay, so that was diarrhea. So now constipation: decreased water in stool. So that's really how we talk about constipation. It's defined as infrequent. So I guess this is also how we define or think about constipation: infrequent or difficult defecation. Okay, so that's actually more accurate. So infrequent or difficult defecation, and then we can see there are a couple of categories of that. Normal transit, so it's moving. There's difficulty in defecation, but it responds to fluid and fiber intake. So things are sort of moving along just fine. And then there's slow transit. Slow transit, infrequent bowel movements, and that's usually going to be neurogenic. Okay, so normal transit, slow transit. So, and so it kind of, I guess it kind of makes sense. Problems that may lead to constipation: neurogenic disorders. Okay, so it's going to lead to a slow transit constipation, where you have infrequent bowel movements that don't respond to fluid and fiber intake. hypothyroid medications, low residue diet. So by low residue, we mean like low fiber, sedentary lifestyle, excessive use of antacid, changes in bowel habits. Okay, so that holding it in can cause can actually lead to constipation. Okay, so make sure people stay regular if at all possible. Okay, so that was constipation. Now intestinal obstruction. Um, and that's exactly what it says. It's obstruction. So you're obstructing the intestines. You're not allowing the chyme to move through the intestines. So it may affect the colon or the small intestine, maybe chronic or acute, like many of these things. But it's there are a couple of different categories. It could be mechanical. Okay, so these are interesting and actually pretty easy to keep the symptoms of these straight. Mechanical, something physically inhibits movement. So severe colicky pain, borborygmus, so rumbling or a gurgling noise. Okay, so that means that your intestines are still working. They're trying to push it through, but something is getting in the way. Something is preventing that uh, from moving the way that it's supposed to move. Okay, so it may be moving, but it may have to pass or bypass some kind of an obstruction or get through some kind of a constriction or something like that. So also audible high-pitched peristalsis, peristaltic rushes, and you have an awareness of intestinal movement. So you can sort of feel like a pain in there that feels like something is moving around, and you can kind of almost sense that there's something going on in there. So those are mechanical. So that's a mechanical obstruction. So there's something else called a paralytic obstruction. And that's when movement stops due to neurogenic or muscular impairment. You're not able to push the food or the chyme, whatever you want to call it, through. You're not able to push that through. And so you're going to notice a continuous pain. Remember up here we were talking about severe colicky pain, pain that would come on rapidly and then go away. This is continuous pain, okay, because you're really not making a lot of progress, and a silent abdomen. Okay, silent abdomen, why is it silent? Because you either don't have the nerves to activate the muscles, or your muscles, the muscles of your GI system are impaired. One or the other. But either way, you're not pushing the food through the way that you need to. Okay, so causes of obstruction, intussusception with invagination. Now this looks horrible. In my mind, it almost looks as though this part of the intestine is trying to digest this part of the intestine. It's almost like it's sort of taking it over and trying to suck it in and pull it through. Okay, now I don't know if that's actually what happens, but that's kind of what it looks like. But it ultimately leads to a shortening of the bowel caused by movement of one segment of the bowel into another, which is what we see here. Okay, so movement of one section of the bowel into the other. Okay, volvulus of the sigmoid colon. Now that's pretty, the sigmoid colon kind of has this S shape, okay? And so as feces moves through here, it has to move around that area. But sometimes, and this is not incredibly common, but it does happen, and it gets twisted. And the twist is usually in a counterclockwise, um, it's a counterclockwise twist, okay? Which is what this picture is showing. It sort of twists around, and then you have a blockage, okay? Okay, and this says note the edematous section of the bowel, okay, which I guess is saying that this is kind of expanding here in this area and becoming edema. There's some edema that's happening there. But either way, it doesn't look good, and it's obviously a mechanical obstruction. And then hernias. So an inguinal hernia. You may have heard of an inguinal hernia. I'm not sure. But that's what they used to test boys for, like when boys went for sports, like in high school, or of course it's tested your whole life, but that was, well, my first experience with it. Anyway, so what happens is that when a baby is born, its intestines are clear up here, up in the abdomen, and then they will move down, and they have to move down through this peritoneal sac, and so they have to move down into this area, and it leaves a weak spot. And so any kind of straining or uh, muscle use where you put pressure in that area can push open that weak area, and then the intestines can kind of move down into that area. So that's also, I mean, that's clearly an obstruction of the intestines, if they're sort of moving down into this through uh, this inguinal weak spot. And so that's the testing that's done. The turn your head and cough. You put you sort of feel up in this area with your finger, and then when you put any kind of strain on it, you can feel this pushing, the intestine sort of pushing down into that area, and that's something you can actually feel. Okay, to test for that. So the sac of the hernia is a continuation of the peritoneum of the abdomen. The hernial contents are intestine, omentum, or other abdominal contents that pass through the hernial opening into the hernial sac, which is what we see here. Okay. Okay, so that's a hernia. So the results of obstruction. Well, we can kind of probably figure out some of these. Vomiting leads to fluid and electrolyte loss. Well, if it can't go through, then it's going to have to go back out the other way um, to clear it somehow. Fluids move into intestinal contents, so that you can kind of see this gas and fluid accumulation that might take place. So here's our obstruction right here. Okay, in this particular picture. And so you can see gas and fluid accumulation, distension of the bowel. So you can see, that's what we have labeled here. So you can see that it kind of stretches in front of that obstruction. Compartment syndrome leads to ischemia, necrosis. So you can see that, so ischemia or necrosis of the bowel. So it's not going to get the proper blood flow to that area. And then anaerobic bacteria. So now you've got a little growth chamber for bacteria to kind of grow and then not be flushed out as necessary. Okay, so that can cause a problem as well. Okay, so that's sort of moving through. So now we move through the small intestine and the large intestine, the colon. So now we're getting into something called peritonitis. Now the peritoneal cavity surrounds the entire gut area, okay, or most of it anyway. You have a few things that are retroperitoneal, like the kidneys. The kidneys kind of sit back behind here, behind the peritoneal cavity, so they're called retroperitoneal. But the peritoneal cavity kind of encloses a lot of these organs, the GI organs. So peritonitis, it's an itis, so it's an inflammation, is inflammation of the peritoneal lining. So the peritoneum is capable of containing an infection by profound inflammatory response with secretion of lots of fibrous exudate. So any kind of perforation, anything that leaks out of the GI system and into the peritoneum could cause then infection of the peritoneal lining. So your body is pretty much tuned in to have a at my sister's, and she has dogs and they're barking. Um, but it can cause an infection in this area. So peritonitis caused by infection. Bacteria enter via a break in one of the abdominal organs. So one of the abdominal organs specifically that's contained within the peritoneal cavity. Could be caused by chemicals. Could be a complication of other problems or other infectious agents coming from other places. So it may not necessarily have to come from the bowels. Um, it could come from damage from the outside or something like that. So it's acute pain, point-specific, aggravated with movement, a rigid board-like abdomen with guarding. So you're in pain and you don't want to move in the wrong direction, because now we're talking about not just the gut, we're talking about this peritoneal cavity, okay, or the peritoneal lining. Okay, so two more things that we're going to talk about, pretty much, and then one more. So alterations in intestinal absorption. Okay, so we've gone all the way through from the esophagus through the colon, and then we talked about the peritoneal cavity. Now we're talking about things that alter the absorption that takes place, and a couple of these are very, very, very important. Malabsorption syndrome and celiac disease. So we'll start out with malabsorption syndrome. Um, Something prevents the bowel from absorbing nutrients or fluids. Okay, so some examples: lactase deficiency. Now, lactase is just an enzyme that breaks down lactose. So that's a milk sugar. So that's a sugar that's found in milk. And most people in the world, after their babies, will stop producing lactase. And so that means that they would normally stop drinking milk, because most mammals don't drink milk after they're a baby. However, humans have, through necessity for survival in certain areas, have evolved to, so mostly Northern Europeans, some areas in the Middle East, they have evolved to rely on milk year-round and through their entire lives. And so so they produce lactase, but most of the world has not evolved in that direction, and so most people stop producing lactase after a while. So um, lactase deficiency can set in. Enzymes that break down lactose are underproduced, leading to lactose sensitivity or lactose intolerance. We often hear about lactose intolerance, but what most people have is lactose sensitivity. That means that they still have the gene to make the lactase. It's just that after they're a baby at whatever young age, they just simply make less and less and less of it. So a lot of people can retrain themselves to make lactase. They can sort of trigger their body to start making lactase again. And that's usually, people who are lactose sensitive can retrain themselves little by little to start producing the lactase again. But like I said, certain populations just continue to make it throughout their whole lives. Lactose intolerance, not so much. You aren't able to make that lactase. It's just simply not there. So that means that any kind of sugar that gets in there is just something that moves right through, can't be absorbed. It can feed other bacteria, which can cause some pretty serious GI problems. So that's one malabsorption syndrome. Bile salts may not be produced by the liver, so fats can't be efficiently broken down and absorbed. Okay, so we're going to talk a little bit more about that when we talk about liver function. But that's kind of an important thing for fats, is that you have to be able to make bile salts. If you can't make bile salts, you can't break down fats. And so that means you would have to pretty much, if you can't make them at all, you're going to have to avoid fats almost completely. Okay. The other problem with that is that you need fats to sort of dissolve, if you want to use that term, the fat-soluble vitamins. Okay, so these vitamins wouldn't be soluble in the intestinal contents without some kind of fat, and that's how they're absorbed. So if you're not eating fat, then those won't be absorbed, and then you're going to have a deficiency. Okay, so and these are just a couple of examples, and there are lots and lots of malabsorption problems. But depending on what the deficiency is, symptoms may include diarrhea. So these are really common: flatulence, bloating, abdominal cramps, weight loss. Okay, celiac disease. So celiac disease, this is one of those things. We're talking about gluten. Okay, so maybe you've heard about people who have sworn off gluten. They don't eat gluten, and then this is often the issue. Okay, I've been through this lots of times. It's okay. You don't eat gluten. Do you have celiac disease? No, it just disagrees with me. Okay, so all the science says that that shouldn't happen. That if you don't have celiac disease, you should be able to handle gluten just fine. However, people swear that when they eat gluten, which is this protein found in wheat, that they swear that it causes GI problems. They swear it causes a lot of different things. So I don't know. There's still a lot of research being done on it. But what we're interested in is something called celiac disease. And celiac disease is a genetic disease where you are unable to break down gluten. Okay, so T cell immune mediated response against gluten leads to intense inflammation, or it's okay. So T cell immune, it's a response against gluten. So that's sorry, I misspoke when I said you can't break it down. It means that you actually have a response against the gluten. Okay, so you recognize this as being some kind of an antigen, and that can then cause an inflammatory response, an immune mediated inflammatory response. And so the only thing that someone with celiac disease can do is to avoid gluten completely. Okay. Um, so when this occurs, okay, so when you have this inflammatory response, it leads to a loss of absorptive villi in the small intestine, okay, which is going to reduce the absorption of lots of different things. Um, it's a lot of times celiac disease is seen in people with other autoimmune diseases like diabetes and hypothyroid. So we saw that a little bit earlier as well. Associated with a risk for various malignancies. So that's not very fun. And manifestations, how it manifests varies with ages. Now, I've known a lot of people with celiac disease, and some do just fine, but they absolutely have to. It's really fun going to a restaurant because they really need to go to a restaurant that absolutely has a gluten-free menu, and it has to truly be gluten-free, not just oh yeah, I don't think this has gluten. It has to be gluten-free because this can be very, very serious if they get gluten in their diet. Okay. So that's celiac disease. All right, so, and then the last a couple of things I just sort of left added on here. Um, we're talking cancer or neoplasms, okay, colorectal, because this is a pretty common type of cancer. Um, so you can develop adenomas. So remember, an adenoma is benign. Um, so it could be tubulovillous. So several different sources of these tumors, and then adenocarcinoma, which are malignant or cancerous. Okay, and so this is why getting screened early is very important. And a lot of times they'll find these diverticuli, and then you can sort of become aware. The patient can become aware, and you can sort of work to prevent this from taking place. Okay, well, that's it for this section or this chapter.